Okay, here we go. Okay, so nursing care, mother and infant during um, and nursing care, mother and infant during labor and also birth. So you have to make sure you understand the key terms. So in this one, we're gonna be looking at the monitor to see how we can look at certain, the monitor when we're looking at the fetal heart rate, when we're looking at the mom's heart rate. All of this is during labor and also birth and the nursing care that we must complete. We already talked about the different complications of with the mother during prenatal care, during the early prenatal care part of it, and also during the late. And we also found the different complications such as preeclampsia, ectopic pregnancy, which is, during the early part, and then you have the preeclampsia during the later part of it. And we also seen um, the gestational hypertension and also gestational diabetes and some other complications that the mother can actually go through. So, childbirth is a normal physiological process, and that involves the health of the mother and also the fetus, who will become part of our next generation. So the nursing care is unique because every nursing intervention that we do, that we implement, everything we do is going to really kind of involve how, we take care of the mom and the baby, which are our patients. Because now in labor and delivery, another difference between with that is you taking care of both the mom and you're taking care of the babies or the baby or the babies. Um, and so, so it's a lot that's going to be involved. And it's going to be, communicating, a lot of, just a lot of obstetrical care that we're going to be doing. So now when you go into the labor and delivery, you're going to include the whole family in it because the father's going to be involved in this, the grandparents, the siblings. So everyone is basically really going to be really involved when it comes to the nursing care of the mother and the infant during labor and then birth. Okay. So a great nursing tip is the bedside nurse is a labor and delivery unit, in a labor and delivery unit. It basically bridges the gap between sophisticated technology and the individual patient needs, providing a positive outcome both physically and also psychologically. And again, those of you who do want to become labor and delivery nurses, that's like the most wonderful role that any person to me on earth can actually do, because it's you are there physically, you're doing everything, to getting the mother prepared psychologically and helping the baby. You're doing so much. But just to be a labor and delivery nurse, you're bringing life into the world. And you're bringing all your skills there, being a nurse, and also some of them, being a mother yourself, and kind of can help someone being a new mom get through everything. So when we look at this, we always want to look at the cultural influences on birth practices, because so many different cultures, they view the practice of birthing differently from probably how you or myself, and a lot of every culture is different. So the way you see the birth practice and how things should be, they may see it differently. They may prepare differently. They may handle like the whole labor and delivery differently. You may see one person go in there just screaming, 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 and then another person just being really like just quiet and stoic and not expressing anything towards pain at all. So cultural influences on birth practices is so different that it's nothing that you have to really kind of sit down and learn, like, oh, this is how this one do it, this is how this do it. It's a learned experience. It's something that if you're working within that area, it's going to be more of a learned experience than anything, because then you'll see the different cultural preferences and how to kind of be flexible in regards to that. The role of the father or the partner in labor and delivery may be driven again by cultural practices. Your book gives a very great example when you look at table 6.1. It talks about the birth practices. Um, it talks about the birth practices. I might be cracking up a little bit because now it's saying that my internet is unstable. Okay. So, um, so when it talks about the birth practices of selected cultural groups, it shows the role of the woman in labor and delivery, and it also shows the role of the father of a partner in labor and delivery. For example, it talks about the American Indian. You know, so the role of the woman, she may be stoic, and the father may avoid eating meat during a prenatal phase. And in the Arabic community, the woman may appear passive but expressive, and the father may not be expected to participate, but may remain in control. In the African community, the African American often participates actively, and female attendants are usually preferred during that time. So when you look at it, so it breaks it down into different areas in your book that you can just kind of look, overview. But again, it's a learned experience. It's really going to depend on actually, like, if you're working in labor and delivery and what you see at that time, and then you get used to it. So it's very, very a learned experience. So when we go into the setting for childbirth, setting for childbirth, I can take you way back to how it used to be a long time ago. Like, again, I started nursing at 14 years old. So when I was 14, the setting during that time was everyone, it was like a ward, a whole big ward. And, you had like bed to bed, maybe like 10 people in the same area. I've seen probably, maybe a decrease of maybe a smaller number, maybe 5, we're all sharing the same room. We have the curtains in between. And, the nurse are using, they're washing their hand. They had the sink in the room still, or one sink in the room, and they use that sink to wash their hands. They'll bring the baby in so you can, so you can see your baby, and they'll bring the baby in. You didn't have that whole rooming in part where the baby would actually stay there. The mothers would go see the baby, and they'll bring the baby to you, take the baby out. They wanted the mothers to actually really get rest and sleep. Unlike now, they bring the baby, and you can have that whole room in where the baby could stay with you because it's a private room. You don't have like everybody, 10 people in one room. The dad will be in there, the grandparents, people can visit, and they'll all be there. During the birthing process, prior to pandemic, during the birthing process, you can have a certain amount of people in there to see the whole birth. I know when my daughter gave birth, I swear it was probably like 10 people in there when she gave birth. But everyone can be in there. It's like a whole family event. So, but it's a beautiful birthing. They have everything really set up. Most hospitals are really changing everything the way they actually set up a whole environment. And they do show a picture here of a typical labor and delivery room in your book. And it's, some women choose to be very traditional and have the whole birthing process there in the hospital. And others choose to be more like in a freestanding birth center, or some others may have more like a home-like setting to have everything. Usually, they have advantages and disadvantages to a lot of different things. So, for example, the advantage of having of the baby in a birthing setting in a hospital would be, if it's any type of complications, you're already there. The doctors, everyone is there. You have the ability to provide more like a centered care for any woman who has actual any type of complication. In a freestanding birth center, a disadvantage would be a slight but significantly delay in like an emergency care, for example. If it's in a home, again, if it's in a home, everything you have, everyone's there. You have, you know, um, even though it's a low technology birth, it's important for some people to have that really at home setting. But then again, the possibility of like an emergency arises, that's going to be one of the disadvantages. So when we look at the birthing process, you have the components of the birth process. And this is really good for you to kind of understand and remember and to know your 4 Ps, because you're going to have the powers, then you're going to have the passage, and you're going to have the passenger, and you're going to have the psyche. And those are going to be your 4 Ps. And that's your whole birthing process. The 4 interrelated components, the 4 Ps, the powers, the passage, the passenger, and the psyche. And this is going to make up the process of the labor and the birth process, okay? So your first one is the powers. And there we go. So your first one is the powers of labors. So when you think of the powers, you're going to think of the contractions. You're going to think of the force, like the whole uterine contractions. So the powers of labors are forces that cause the cervix. Remember where the cervix is. It's going to open, and it's going to propel the fetus downward through the birth canal, which is the vaginal canal. And the 2 powers are uterine contractions, okay, how it's contracting, and also the mother's pushing efforts, which is going to happen as the baby begins to descend a little bit more down. So if you remember powers, like powers, the force, that'll be really great to let you know that's what powers mean, because it's going to be, again, the uterine contractions and the mother's pushing efforts. So you have those uterine contractions, okay? And I'm just looking to make sure the slide. Okay, here we go. Preparation, position, professional. Okay. All right. So here, this slide, let me just look at this slide really quick. It talks about the factors that influence the progress of labor for you. Okay, so you have to prepare, the mother has to be positioned, professional, everybody there, the doctors, the nurses, the place, the setting. What kind of procedure? Is it going to be a cesarean? Is it going to be a vaginal delivery? And the people, the family, okay? So your uterine contractions, so we're looking at the powers still. So uterine contractions are the primary powers of labor, because this is going to happen during the first of the 4 stages of labor, okay? So it's going to start from the onset until the cervix is fully dilated, because once the cervix is fully dilated, that's when we go into the second part of the P, okay? Which is that's when we start talking about the passage and how the passenger, which is the baby, is going to go through. So now you have the uterine contractions. Basically, they are all involuntary, smooth muscle contractions. And the mother, the person that's actually delivering, she cannot consciously cause them to stop or even begin. So their intensity and effectiveness are influenced by a number of factors. So sometimes, like those of you who had a child before, the doctor may say, okay, you start feeling these intensity of the contractions. The doctor may say, okay, get up and walk around a little bit, breathe, just something natural. And then after that, if it doesn't usually work, they may give you something to kind of help that with that intensity or the pain and so forth. And then, and sometimes, the mother will have these anxieties and so forth. Sometimes even just going into like checking the mother, doing a vaginal examination, checking the cervix, sometimes that can influence the intensity of these contractions. So effects of the contractions of the cervix. So when you're looking at contractions, in your book, it gives really great pictures so you can kind of visualize this. I know I have a great video of this. I just have to find it so you can see what it looks like with the whole effacement, and when they talk about the frequency and the phase and everything else. So I have to look for that video so you can actually get a good picture of it. Because that's to me, seeing a delivery, it kind of really helps a person. So let's think of the contractions are starting, okay? So contractions, when the contractions begin to start, the power, the force, the movement. So you have the contractions are really starting. So when a contraction starts, the cervix doesn't only dilate or open, it begins to get thinner. So that's what we call effacement or efface, because it's going to do those two things. The contractions are going to cause the cervix to efface, to get thinner because it's widening out, and along with that, it's going to actually dilate and begin to open. Because now the fetus is beginning, the passenger who is the fetus is beginning to go through the passage, which is the vaginal canal. So so the power, which we're talking about the contractions, is going to allow the fetus to descend into the birth canal, okay, to open up that passage. So now the passageway is about to open. So basically, before labor begins, the cervix is a tubular structure, which you've seen how the cervix looks. It's really tubular, about 2 to 3.8 centimeters long. So the contractions begin to simultaneously push the fetus downward as they pull the cervix going upward. So when it goes upward, it's going to be an action similar to pushing a ball out of a cuff or a sock. So your book gives that description. So if you have if you have a ball in your house, a little baseball, and you put it in the sock, and I would just tighten the sock on the bottom, and then take it and just begin to squeeze, it'll open. Or those of you who bake, think of that where you put the frosting inside that tubular thing, when your frosting's in there, and then as you squeeze that tube, it begins to stretch out, and you give that thin, it begins to thin at the end and open. So that's almost similar to the passenger now is going through the passage, or the cream is going through there. I'm sorry to mix the birthing of the baby with the making of a cake, but I had to think of something. Or the sock, that's good. Your book talks about the sock. So basically, this causes the cervix to become thinner. So when it pulls out, it's going to become thinner, and then it's going to bring it up, and it's going to become shorter. So the cervix is losing basically the length of it. So the effacement is determined by a vaginal examination, and it's also described as a percentage of the original cervix length, okay? Because the cervix is starting to lengthen out, which is effacement. So when the cervix is 100% effaced, it feels like a thin, slick membrane over the fetus. So let's look and see if we can find a picture. So remember we talked about the internal os and the external os earlier when we were talking, I think, I forgot what chapter it was, but we talked about that, where, hold on. Okay, great. Just want to make sure I have the recording on. Where we talked about internal os, I said, remember what the internal os is. That's closer up to the cervix. The external os is closer to the vaginal canal. So now the baby is beginning to descend. The passenger is going through the passage. So as it goes through the passage, the internal os begins to lengthen out, to efface, as the baby is descending down into the external os, going through the cervical canal. So figure 6.2 is showing you cervical effacement and also dilation. So picture A, it shows no effacement, okay, and no dilation at all. B shows early effacement and dilation. As you look at the internal os, where the baby head is up on top, a little further up in the cervix, and then the external os begins to open up a little bit more. So it has some early effacement and dilation. Picture C, it shows complete effacement and some dilation. And picture C is like 100% effacement, which is complete dilation and also effacement. Okay. So dilation and effacement is determined during the vaginal examination. So the dilation is going to be described in centimeters, with full dilation being like 1 centimeter, 2 centimeters, you know, and then the effacement is going to be like in more in it's going to be considered more in percentage, like we said, 100% of effacement. Okay, so when you have the cervical dilation, which it shows you in figure 6.3, the cervical dilation, again, is in centimeters. And when it gets to that whole 10 centimeters, you're going to have a complete or full dilation, because the doctor's going to say it's 10 babies at 10 centimeters. So now now we're still under what we call the powers. So we said the powers already. It's basically the contractions, what's going to bring on that effacement, what's going to bring on that dilation, what's going to bring it on. So you're going to have the different phases of contraction. So each contraction, they have the 3 phases. And so when you're looking at the phases, you're looking at the intensity of it, and the powers, because we're still talking about the powers. So you have the increment part, which is the period of increasing strength, and then it's going to reach that full peak. So if you think of a curve, and it shows you really great in your book, when you look at that curve, it's going to be the curve. So during that curve, at a certain point, that's where when you hear the mother scream the most. So when it's going into the increments, it's going to go into the increasing period of strength, because the contractions are getting ready to start, so they're going up in strength. Then it's going to reach a peak or acme, which is the period of the greatest strength. And that's when the contractions are the hardest. You probably put your hands on the mother's, stomach, and you're going to feel that peak where it's really, 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 really hard. And then after a while, it's going to be the resting period where it begins to decrement, the period of decreasing strength. So those are your 3 phases, okay, of contraction. You're going to have the increment period phase, you're going to have the peak or the acme phase, and you're going to have the decrement phase. So during your peak phase or the acme phase, this is when the mother can say the intensity of it can be mild, it can be moderate, or it can be strong. So that's during the peak phase. And then when you go after a while, like I said, it goes down into the decrement, where it begins to lessen. So in your book, it shows, figure 6.4, figure 6.4, page 127, it's right there. It shows you a little, it shows you, exactly what I'm talking about. So you have when it's during that time, we look at the duration, how many seconds, we look at frequency, we look, how many minutes and fractions, like of the minute, that these contractions are actually happening. Okay, so figure 6.4 actually shows you that. Okay, so now, so now now you know about the increment, the peak, and then you have the decrement. So contractions are also described by their average frequency, how frequent it's going to come, how long it'll last, the intensity, and also the interval in between the next contraction. Okay, and your book goes pretty good in detail. So you're looking, we're still within the powers, of everything. So this is what happens, as the baby. So when you're looking at the strong contractions and the minutes and how long the frequency is and the intensity. So this is everything that happens, so that, again, like I said before, so that the cervix can begin to dilate, and so that it can begin to efface, and so that it can make a really great passenger passage, which is through the vaginal canal, for the passenger, which is the baby. Okay. So now the frequency. So the frequency, how frequent is it going? Is so frequency basically in your book it says frequency is the elapsed time from the beginning of one contraction, okay, the beginning of one contraction until the beginning of the next contraction. How frequent? Like frequent. From the beginning of one contraction, the contraction starts, boom, continues because it's going to go up, and then it's going to hit the peak and then go down, and then it's going to wait a little bit, then the next contraction is going to start. So from the beginning of our first contraction until the next. So frequency is going to be described in minutes, in fractions of minutes, such as contractions every 4.5 minutes. So it depends on like that, okay? And contractions occurring more often than every 2 minutes may reduce fetal oxygen supply. And that should be reported because remember the powers. So if you're having contractions and it's becoming really, really intense and the baby is really trying to push, they're using a lot of their energy. So if they're doing this, they can lose oxygen. Okay, so you're looking, so this is why you have to not only just monitor the mother's vitals, you're also monitoring the fetal heart rate and everything else also to see if it's going to have a low, if the heart rate is going to drop during this time or if it's going to increase during that time. So now let's look at duration. So duration is going to be, duration is elapsed time from the beginning of contraction until the end of the same contraction. How long that one contraction is going to last. So when you describe duration it's going to be basically in seconds, like 45 seconds, 50 seconds, 60 seconds. So persistent contraction duration is longer than 90 seconds may also reduce oxygen supply and should be reported. So anything longer than that 90 seconds, again, because it's the powers, the baby is pushing and working and it's getting tired. So think of yourself pushing something and you keep pushing and pushing and pushing, you're gonna get exhausted, you're gonna get tired. Like if you're on a treadmill and you're pushing yourself too much, you're gonna get exhausted, you're gonna get tired because you're using a lot of power from your body. And then you have the intensity. So the intensity is like right in the middle where the peak is. So intensity is the approximate strength, how strong it is, boom, of the contraction. So in most cases, intensity can be described like I said earlier, mild, moderate, or strong. Okay, so when you have those mild contractions, so let's go back and look at those mild contractions. So I want you to think now like you're walking up a hill, right? And you're walking up this hill, and that's going to be like the increment that you're going up. And then when you reach that whole peak of the hill, and so you're like right there. So either you're going to be mildly tired, moderately tired, or strongly tired. So that can kind of just, so you're trying to really catch your breath at that time because you reached that top of the hill. So think of mild contractions. So mild contractions, so the fundus is easily indented with the fingertips. Because it's mild, it's not really strong, and you can feel it, because it's with the fingertip. But when it's a moderate contraction, the fundus can be indented with the fingertips, but it's going to be a little bit more difficult because it's really hard because it really struggled to get up that hill. So the fundus of the uterus feels similar to the chin. So if you touch your chin, it's still soft but firm at the same time. But when you really got that firm contraction, the fundus cannot be really easily indented with the fingertips. The fundus of the uterus may be similar, like if you touch your forehead, which is really hard. That is really hard because you already went up that hill and it's so strong, you're so tired that it's going to be that intensity of it. It's going to be like, boom, it's going to be heavy on you. So that means that those contractions are hitting the mother really, really hard. So then you have the interval, okay? So the interval is the amount of time the uterus relaxes between contractions, okay? So the blood flow from the mother into the placenta gradually decreases during contraction. and then it resumes during each interval. So when it reaches that peak, at a certain point, it's going to just be, you know, it's going to be like to the point like now you're at that peak. So now it has to, at some point, it has to kind of calm down and relax. Blood flow has to get back to the baby, and, to prevent any type of fetal hypoxia. This is why we gave you those numbers earlier, like the 90 seconds and so forth. So you want to make sure you write all that down, because it's very important, because you're looking at what can cause fetal hypoxia during the times of contraction. So blood flow from the mother to the placenta gradually decreases during contraction, and then it resumes during each interval. So the interval is very important, because this is when you want to get that blood flow for the placenta to fill back with the freshly oxygenated blood for the fetus, and also it's going to remove that fetal waste and everything else. So, but if it continues to be persistent, like for persistent contraction, intervals are shorter than 60 seconds, it may reduce fetal oxygen supply, because it's not giving it that time to return that flow back, so it can build up the oxygen that the baby actually really needs. So again, you have those safety alerts in your notes in your book, so make sure you look at those and read it and write it down. It gives a really great one about when to report to the registered nurse about any contractions that occur more frequently or whatever, in the 2 minutes and the 90 seconds and the 60 seconds that we spoke about, okay? Now we're still talking about the powers, okay? So within the powers, okay, we talked about the contractions and everything else. That's all of your powers. So, but when it comes to maternal, so that's natural. So that's just basically health happening on its own. The mother's not pushing. This is just something really happening on its own. But when you come to maternal now, the maternal pushing, okay? So when the woman's cervix is fully dilated, remember we said 10 centimeters is fully dilated, because now it's really open, and the cervical canal opened up, because now it's ready to go through the passage, which is the vaginal canal, the pelvis, and everything else. So it's getting ready to do that. So when it's very dilated, she adds voluntary pushing to involuntary uterine contractions. So the combined powers of the uterine contractions, and I'm just reading this from your book. So the combined powers of the uterine contractions and voluntary maternal pushing in stage 2 of labor propel the fetus down through the pelvis. Most women feel a strong urge to push or bear down when the cervix is dilated and the fetus begins to descend. However, factors such as maternal exhaustion, or sometimes epidural analgesia, which we're going to learn about in chapter 7, may reduce or eliminate the natural urge to actually push. Some women feel a premature urge to push before the cervix is fully dilated, because the fetus pushes against the rectum. This should be discouraged, okay? Highlight that. That should definitely be discouraged, as it may contribute to maternal exhaustion and also fetal hypoxia, because you're putting power upon power, pressure upon pressure. So therefore, you can cause too much, things acting a little bit too quickly, and also you can cause tearing of the maternal soft tissues. So, so the practice called basically, quote, quote, laboring down or controlled pushing. We're gonna talk about that later. It's gonna be discussed later on, okay? Now, so now, again, you wanna definitely read your nursing tip. So let's look at this passage. Okay, so now we got the powers. The contractions already started, okay? And these are your contractions. They already started, and we looked at the effects of contractions on the cervix, which is efface and dilate. We looked at the phase of contractions, which is the increment, the peak, and also the decrement. We looked at what frequency means, duration, intensity, which is mild, moderate, and firm. And then we looked at what maternal pushing was. So now we're into passage, okay? Custodial passage. The passenger, who's the baby, has to come out. So this is when we start looking at the passage and how the fetus comes out. Remember when we were in chapter 2, we looked at the structure of the bony pelvis. The gynecoid was the most favorable one, but then you have some which were not favorable. And we also looked at the pelvis, and we talked about what's the true pelvis and what's the false pelvis. So now we're starting to look, now this is going to, those words that come, vocabulary words, are beginning to basically come back to you. So when you so the passage consists of the mother's bony pelvis, soft tissues, which are the cervix, the muscles, the ligaments, and also the fascia tissue. So you have all those muscles and all those tissues surrounding the pelvic area. Also, the perineum is there, because remember we talked about the perineum, because that's another important part that's there, because when it's time for the baby, the passenger, to come out, the perineum is one of the parts that's very important, where the doctor can actually cut it, to the area there, or it can actually tear. So you have the bony pelvis. So the pelvis, again, when you look at the pelvis, it's going to be divided into the following 2 major parts, which we talked about earlier in chapter 2. We have the false pelvis, which is the upper part, the flaring part, and you have the true pelvis, which is the lower part. And when it comes to the true pelvis, this is the part that we look at, because that's going to be really involved in the passage for the passenger, which is the baby. Okay, and so when you're looking at the bony pelvis again, it's divided into the inlet at the top, and the mid pelvis, which is in the middle, and the outer near the perineum. And then again, it's the pelvis. If you look at how the pelvis is shaped, it's like a curved like cylinder, or like, just basically like a funnel for the baby to go through. So remember we talked about how the doctor goes in, they measure it, because in this way we can see whether or not the fetal head can pass through it, and also the shoulders and everything else. So if not, then this is when C-section can be indicated in some cases. When we look at the soft tissue, in general, women who have a vaginal delivery usually deliver more quickly than a woman having their first births, or if they had a C-section, because it kind of already is there and it's also prepared. Just to read from your book, it says, in general, women who do have or have previous vaginal birth delivers more quickly than women having their first birth, because their soft tissues yield more readily to the forces of contractions and also the pushing efforts. This advantage is not present if the woman's previous birth were cesarean sections, because the soft tissues may not yield as readily, and an older mother or after cervical procedures have caused all that scarring. So just keep in mind, any place where there's like a lot of scar tissue is going to cause a lot of problems and difficulties, and we just see that earlier in the earlier chapters when we talked about the placentia abruptio, where sometimes having the scar tissues or any surgeries or complications prior to them can be a probability for the cause of that. Okay, so now let's see. So now we already see the passage, okay? And so that's the passage. So let's talk about passage. So let's talk about our passenger who's going to be actually going through this. Where is my passenger? If I didn't put it in here. Oops, okay. So the other one, the passenger. So here it talks about the psyche, which is the mental state can influence the course of labor, and the woman's cultural, individual values influence how she would cope with childbirth. So, so now, what else comes through? Nope, doesn't have. Okay. So let's talk about a little about the passenger. So the passengers are the fetus, and also the placenta, which is the afterbirth, amniotic, membranes, amniotic fluid, all that has to come out. So all those are considered to be basically the passenger, because the fetus usually enters the pelvis head first, which is a cephalic presentation, and that's what we want. So the nurse should understand the basic structure of the fetal head. So We do. We have to look at the basic structure of the fetal head. And so in that way, you can kind of get kind of understanding in which the way the passenger is actually going through. So the fetal head is composed of different several bones separated by strong connective tissues. When you look at the sutures, you have that, and then a wider area is called the fontanelle. It's formed where the sutures meet. So you have the following two fontanelles are very important when it comes to obstetrics. You have the anterior part and you have the posterior part. We call those the anterior fontanelle and the posterior fontanelle. Um, and your book does go through it a little bit more. But figure 6.5, it shows you the different shapes and everything of the head. But just always remember the anterior and the posterior. So that's really great for you to kind of know. And that, and the sutures and the fontanelles of the head, it basically allows it to change shape as it passes through, because it's like that molding effect. And sometimes you see when the baby passes through, it has a different shape. So it can, sometimes the doctors can actually like mold that, fix that area molding. But it's more like a molding effect. And they are important landmarks in determining how the fetus is oriented within the mother's pelvis during birth. So we're going to look at those oriented and the language for that. So the main transverse diameter of the fetal head is the biparietal diameter, which is measured between the points of two parietal bones on each side of the head. And the anti-posterior diameter of the fetal head can vary depending on how the head is flexed or extended during that time. So some of the words that you're going to familiarize yourself with will be just looking at the fetus, how the baby lies, L-I-E, or lying down in the position. So when you look at how the fetus lies, and I'm looking for the slide right now, and emission, nope, to labor, false labor. Let's see here. No, it's not telling me all that. So let's go back. So we'll just go through that quickly. So about the way the fetus lies. So we have the passenger. So the passenger itself. So when you're looking at the passenger, don't know where it is and what happened to it. Okay. So when you're looking at the passenger, you want to look at how the passenger is lying and presenting itself. So the lie describes how the fetus is oriented to the mother's spine. And so if you think of how the spine is in the back, it goes from up to down. So you want to see exactly how the baby lies. So the most common orientation is the one that you want to look at is the longitudinal lie, and which the fetus is parallel to the mother's spine. And your book does give a wonderful picture of how a longitudinal lie will look. Do you have the transverse lie, which the baby is basically laying on his back, head on one side, head on the other side, like you're actually cradling the baby. So that's so. Then you want to look at, so you got the lie, the way the baby lies and is laying, the way it's actually presenting itself. Again, when it's like that, it's parallel to the mother's spine. And the other lie, it's almost like a cradle effect, like it's, just laying down on its back, and it's a cradle effect. It has not yet turned to actually be able to go through the passage. Then we're gonna look at the attitude of the baby. Okay, so when you look at the attitude, let me see if I can find a picture of that. So when you're looking at the attitude, so attitude is like the word attitude. So when you're looking at the attitude, it's normally one of flexion. When the head, is flexed forward, and the arms are flexed. When with the head flexed forward, and then you have the arms and also the legs flexed. So the flex fetus is compact and ovoid and most efficiently occupies the space of the mother's uterus and also the pelvic. So basically you're looking at a really great extension of the arms and the legs so that labor, so labor can begin. But extension of the head, the arms, and the legs does sometimes occur, and labor may be prolonged. So it's basically, it doesn't, so when you're looking at the attitude of the baby, you know, it's more like you want a nice normal flexion with the head forward and the arms and the legs flexed and not extended. Okay, so it's better to be flexed and not extended. So in that way, it'll be easier for the passenger to come out. So when we look at the presentation, that means that's going to be, you know, the part that's going to present itself first to come out. As the passenger goes through the passage, how is it coming out? Is it going to come out head first? Is it going to come out bottom first? Or is it going to be side transverse and you really can't come out? You need a C-section? Well, how is it presenting itself? You know, so this is what we're going to look at. So when you look, so the presentation again refers to the fetal part that enters the pelvic first. So you have the cephalic presentation, which again, that's the most common. And then you have some other four variations of the cephalic presentation can also occur, depending on the extent to which the fetus head is actually flexed. So that means you have the vertex presentation, military presentation, the brow presentation, and the face presentation. So the vertex presentation, the head is definitely fully flexed. And this is going to be your most favorable cephalic variation because the smallest possible diameter of the head, it actually enters the pelvis, and this occurs in at least 96% of the birth. So everything else, you know, you have some flex, you know, the military presentation is neither flexed or extended. Then you have the brow presentation, then you have the face presentation. So you really, the best way is when it's flexed and not extended. That's going to be the best way. You want that presentation to actually begin to happen. So again, so you have, those are your fetal, so those are your cephalic presentations. But sometimes you may have some other ones. So the next most common presentation is breech, which the bottom actually comes out. So that means you have frank breech, full or complete breech, and the foot length breech, which is one or both feet are present first at the cervix. When you have that frank breech, the fetal legs are flexed at the hip and extended towards the shoulder. This is the most common type of breech presentation. And so the buttocks actually presents first at the cervix, okay? And so again, it's the best one would be if the head is first, wonderful. If it's breech, a little bit more difficult to deliver. So many women with a fetus in a breech position will have cesarean sections because, you know, because the head, which is the largest single fetal part, is the last to be born and may not pass through the pelvis easily because flexion of the head cannot occur. So you try to avoid having that. So the cesarean section is really the way to go when it comes to a breech presentation. And plus, after the fetal body is born, the head must be delivered quickly so the fetus can breathe. So that's another reason why. So at this point, part of the umbilical cord is outside of the mother's body, and the remaining part is subject to compression by the fetal head against the bony pelvis. So this is why, you know, you really want to have that cesarean section. When the baby is in a transverse lie, like I said before, it's like a cradling-like position. The fetal shoulder enters the pelvis first. The fetus is in the orientation must be delivered by cesarean section because, again, it's not safe to deliver through the pelvis. And then we also look at position. So when we look at the position, position basically kind of refers to how a reference point of the fetal presenting part is oriented within the mother's pelvis. So when we look at position, the term occiput is used to describe the head is oriented if the fetus is in a cephalic, which represents the head, cephalic vertex presentation. And then the term sacrum is used to describe how a fetus in a breech presentation is oriented in the pelvis. So the shoulder and the back are usually the reference points if the fetus is in a shoulder presentation. So when you look at that, sometimes you will see like, like first letter, you will look at R, the right side or the left side of the woman's pelvis. So basically, that letter is omitted if the fetal reference point is directly anterior or posterior, such as OA. So, which will mean occipital anterior, like in that way. So to make it easier for you, your book does give box 6-1 classifications of fetal presentations and also positions. So if it's a vertex presentation, it shows you, if it's what LOA means, ROA means, and if it's a face presentation, it'll show you like the inframentum, what that means, or the trend. Then if it's a breech presentation, it'll show you that too, okay? And again, your book gives a really great thing about the different fetal positions and so forth in regards to the ROA and what it looks like, and if it's a breech presentation and what that would look like. Well, mostly it really shows if it's a vertex or, occipital presentation, okay? So now let's look at psych. So with psych is basically talking about the mental state, how it can influence the course of labor, the woman's cultural and also individual values, influence how she would cope with childbirth. So it has all of that. That's what psych really is. And signs of impending labor. So let's see what happens. So different types, we talked about the different signs of labor before, of impending labor. So, when it comes to the Braxton Hicks contraction, so basically the signs and symptoms that labor is about to start may occur from a few hours to a few weeks before the actual onset of labor. So it's really going to depend. So when somebody says they have those Braxton Hicks contractions. Braxton Hicks contractions are irregular contractions that begin during early pregnancy and very intensifying as it gets closer to the baby, becoming like full term. They often become regular and uncomfortable, leading a lot of ladies would say, I'm in labor, and they actually are not. So this is when we talked about the false labor, and so forth earlier when we were talking about false labor and so forth. So all the Braxton Hicks contractions are often called false labors. They play a part of preparing the cervix to dilate and in adjusting the fetal position within the uterus. Then you have what we call as lightning, and increased vaginal discharge. So some of you may have heard of lightning, and that's happens when the fetus basically settles into the pelvis and the fundus no longer presses on the diaphragm. So a lot of mothers in the beginning, when they have the babies are up really high, it's really difficult for them to breathe. But once that lightning house comes, a mother would know. She might say, oh my God, I feel easier now to breathe when I'm walking up the stairs or walking around. So that's lightning, like boom, it just hit, it dropped. But then what's gonna happen, remember we said where the cervix was? The cervix lies between the rectum and also the bladder. Now she's going to be urinating more. She may also have increased vaginal secretions. Fetal pressure can causes an increase in those vaginal secretions, and so she's also going to have it can increase her to have like some type of irritation and itchiness in the area. Then she's also you're gonna bloody show and the cervical changes, and we talked about that before. So again, the cervix is going to be rigid and firm during pregnancy. So as you get closer to labor, it's going to be starting to soften up, and that's when the cervix is going to begin to dilate. So then you have the bloody show. So that's that plug we talked about before. That's going to protect everything from going inside the cervix. So as it gets closer, sometimes, the cervix undergoes all those changes. It softens, it begins to ripen, it begins to dilate, it begins to efface. So when that happens, that mucus plugged, that basically was sealed and to protect and everything else, it starts to break up. So that's when we say it's like a bloody show. And that bloody show is more like a pink or dark brownish. And it can begin a few days before labor, or some ladies say they don't really see it until the time of labor. Okay. The rupture of the membranes can happen. So when they have the rupture of the membranes, which is the amniotic sac, sometimes ruptures begins, ruptures, it can happen before labor begins. And sometimes if that happens, an infection can actually start. So you have that. Another thing ladies have is an energy spurt. And when they usually have that energy spurt, they start cleaning the house, and they usually call that nesting, because sometimes be like they're preparing. They're preparing for the baby to get there and come home. Some ladies may notice some weight loss, maybe 1 to 3 pounds before labor begins, because of the hormonal changes, and excretion of extra body water. Okay. Um, you have the mechanism of labor. Okay. I want to pause this just to get some water. Okay, so now you have the mechanisms of labor. So with the mechanisms of labor, so now we're looking at the mechanism, basically how it descends down and how it engages, and the whole extension, the rotation, in order for it to come, the passenger to actually come through the passage. So when you have the mechanisms of labor, so as the fetus descends into the pelvis, it undergoes several different positions and changes. So it adapts optimally to the changing pelvis. Sorry about that. To the changing, so it adapts optimally to the changing pelvis shape and also the size. So many of these mechanisms are called cardinal movements, and it occurs simultaneously. So just to kind of briefly, your book does talk about the mechanisms of labor. So the first one would be the descent. So descent is required for all mechanisms of labor to occur, and for the infant to be born. So the descent occurs as each mechanism of labor comes into play. So this is when we start talking about the stations. So you're going to have like the negative stations, and you're going to have the positive stations. So it's when you think of anything positive, that means good. That means it's coming closer to actually descending out, through the pelvis. So the station describes the level of the presenting part, usually like the head of the pelvis. So the station is going to be estimated in centimeters from the level of the ischial spine of the mother's pelvis. So it's going to basically start at a zero station. So the minus stations again are going to be above the ischial spines, and the positive stations are going to be below the ischial spines. So as the baby begins to descend, the minus numbers, they begin to decrease, and then the positive numbers again are good. It's going to be that the baby is getting very close to actually descent coming out. Okay, this is when we get into engagement. How is it engaged? And that's the presenting part. Again, so the engagement occurs when the presenting part, usually what we want it to be the fetal head, it reaches the level of the ischial spines of the mother's pelvis. So the presenting part is at zero station or lower, which is going into the positive part. So when engagement occurs before the onset of labor in a woman who has not previously given birth, which we call, remember, no birth at all, never gave birth, which is nullipara, so then you said if the woman has previous vaginal birth or multipara, engagement may not occur until well after labor begins. So depending on how many babies you have and then less babies you have, that's when engagement usually can occur. So then you have the flexion. And so the fetal head should be flexed to pass more easily through the pelvis. And we said that earlier, the way the baby is presented. And then there's the internal rotation when the fetus enters the pelvis. Head first, the head is usually oriented so that the head or the occiput is towards the mother's right or the left side. As the fetus pushes down by contractions, the curved cylindrical shape of the pelvis is going to cause the fetal head to turn until the occiput is directly under the symphysis pubis, which is occipital anterior, basically actually face going out anteriorly. Then remember, if it's more of an extension, as the fetal head passes under the mother's symphysis pubis, it must change from flexion, because remember, as it's descending down, we want it to be flexed. You don't want it to be extended all the way out because it's going to be a little bit more difficult, and that can lead to maybe a C-section. But as the baby begins to descend more down, it's going to change from flexion to extension so that it can be properly negotiate the curve. And so to do this, the fetal neck stops under the symphysis pubis, so almost like a pivot, and the head swings anteriorly as it extends with each maternal push until it is born. So this is when the mother begins to actually help the baby with the pushing as the baby begins to descend down more. Then you have the external rotation when the head is when the head is born in extension, and the shoulders are crosswise in the pelvis, and the head is twisted in relation to the shoulders. The head spontaneously turns to one side as it aligns with the shoulders. So the shoulders then rotate with the pelvis until their transverse diameter is aligned with the mother's posterior pelvis. And then the head turns farther to the side as the shoulders begin to rotate within the pelvis. And then at that time, expulsion begins, where the anterior shoulder is followed by the posterior shoulders. Those are born. And then after that, the rest of the body basically comes through. And I'll definitely make sure that I have a video that actually shows you all these mechanisms of labor. And that way it's easier for you to kind of look at and see, okay? And now, okay, let's see. So now, when to go to the hospital or the birthing center? When do I know to go? When do I know to go to the birthing center? Because now I have to deliver the baby. So when to go to the birthing center? Number one, when contractions begin. Number two, ruptured membranes, what we said before. Number three, bleeding other than bloody show. Number four, decreased fetal movement or any other concerns that the patient may have. So once the baby is there, you have the admission data collection. So you want to look at the admission assessments performed promptly on admission. The baby gets there, because now you have to collect all this information. You want to look at the fetal condition, the heart rate, that's going to be assessed. The maternal condition, the mother, taking her temperature, checking for any type of infections, and the blood pressures, all the vital signs, especially if it's high blood pressure, hypertension showing. Then you're going to look at the impending birth. The nurse continually begins to observe for any type of behaviors that suggest that the mother is about to give birth. So again, you're looking at the fetal monitor, you're looking at the maternal monitor condition. So we're looking at all of that, and so just to go back a little bit, so your book says when a woman is admitted, the nurse begins to establish a therapeutic relationship. She's welcoming, the family's there, and that she has to continue this therapeutic relationship because she's actually going to be the one that's going to be in the room with the mom, the family, and everyone else. So you have to establish all of this. So basically, some women who have a written plan, a birth plan, they already discussed it with their healthcare provider. And they want this and they want all of this, and they're going to want a lot. So this is why, those are your three major assessments. It's going to be performed promptly, and the mother walks in. Yeah, again, you're going to the fetal condition, the maternal condition, and also the nearness to birth, the impending birth. So when it gets to the impending birth, the nurse continually observes the woman for behaviors that's going to suggest she is about to give birth, and that's going to be, she's like she's having those contractions, she's bearing down, she's like the baby is coming, the baby is coming. Um, so skill 6-1, it shows you what to do when you're assisting with an emergency birth. If you're not, they don't make it to the hospital. So make sure you go over that, you look at that, the purpose of it is to prioritize care and to prevent injury to the mother and also the child. Is going to go over the different steps that you actually would do in that time. And then, of course, you're going to have additional data collection, um, you know, that you have to get. So if the maternal and fetal conditions are normal and if the birth is not really imminent, you can get other data collection and just basically the basic information, and the birthing plans, and everybody, the status of the labor should always be evaluated. So you're basically getting everything prepared, putting the mother on the monitor. Um, okay, and so with that, you have your admission procedure, and the mother is there. You want to make sure you get the permits and consent, all the blood work, the laboratory tests that's needed. One of the laboratory tests, you want to get samples of the hematocrit, or some urine. You got to look at the glucose and the protein levels so you can, determine like any, preeclampsia or eclampsia, all those tests that need to be done. Um, and anybody who came in and never had prenatal care, they're going to need additional tests, such as like the CBCs, urinalysis, some type of drug screen, and also tests for STD or sexually transmitted infections, STIs. And so all of those are going to be indicated and need that. IV fluids may be started, just to kind of just to make sure you have an open line, just in case number one of emergency. So you want to have that IV fluid and get that to start administering fluids and any other medication that may be needed, max sulfate, if the blood pressure is really elevated. So all of those you're going to really, really, really need. Perineal preparation, you got to prep for that. If it's going to be a vaginal delivery or removing pubic. So basically your book says removing pubic hair is rarely done now because because routine episiotomy is no longer practiced, number one. And evidence has shown that it does not prevent infection, number two, like before. Okay. And then we're going to also make sure they come in, they're going to determine the fetal position and also the fetal presentation. So that's going to be done. One of the key words you want to remember when it comes to fetal position and also presentation is called Leopold's maneuver. So the nurse can assist the healthcare provider with that in determining fetal position and presentation and also abdominal palpitations called Leopold's maneuver. And when you look at Leopold's maneuver, again, it shows you this. It's something that you'll assist with. I'm not going to go into it, but at least you know what it is. But if you ever do work in labor and delivery, you probably would be trained to actually do that. So when you're looking at comparison of false and also true labor, um, this is a good chart to compare. So this is something I want you to read on your own and look at that. So when you're comparing the false labor versus the true labor, you want to kind of keep that in mind. For example, you see contractions are irregular, and with true labor, contractions gradually develop a regular pattern. And this is when you begin to see the intensity and so forth of it. Usually with the bloody show, they're most often present. You're going to have a more progressive effacement and dilation of the cervix. False labor, you really won't see that at all upon examination. So nursing care after birth. So now after birth, nursing care before birth first. Let's do that. Sorry. I don't know where I got the after from, but so the patient comes in, so you have to monitor the fetus. You're going to monitor the mother that's in labor. and then you're going to help them, basically get through the cope with this whole labor process. So when you're monitoring, you're going to be looking at the fetal heart rate. So that's one of the things you're definitely going to be looking at. So the goal of the fetal monitoring is to enable any type of early detection of fetal hypoxia, very important, which may have causes, and to allow prompt interventions that will avoid any type of fetal injury. So when you're looking at the fetal heart rate, that's going to be assessed. You're looking at the fetal monitor, and the fetal monitor is going to have both the mom and the baby, so you can see exactly both what's going on. You'll see the, any type of decelerations, which we'll look at now. So the fetal heart rate can be assessed by any type of intermittent auscultation, and the doctor usually comes in, uses a fetal scope, or they can use a Doppler, and just kind of do this whole continuous electronic fetal monitoring, which we also call EFM. So the EFM is more widely used in the United States, but but intermittent auscultation, you'll see that used outside, like more, they use more of a fetal scope. So determining fetal heart rate. So your book has that, which is good. And this is chart figure 6-2 when you're determining the fetal heart rate. And I guess this will be a good example about check, gather, hello, ID, privacy, explain, washing on gloves. So you can look at this, and it shows you in regards to the fetal scope, using a Doppler, and external fetal monitoring. And it talks about intermittent auscultation. Okay, so now when you're monitoring the fetus, you're looking at the fetal heart rate. Monitor every 30 minutes and active on the first phase of labor. You want to monitor every 15 minutes in the second stage of labor, and preferably before each contraction. Any type of risk factor present, you want to monitor every 15 minutes in active first stage, and then monitor every 5 minutes during the second stage. And then you have the intermittent auscultation, and also the continuous electrofetal monitor when you're monitoring the fetal heart rate. And again, your book does go more into when to auscultate, and also document the fetal heart rate for women who are low risk, high risk, and also the routine auscultation. Okay, so it has that chart there for you to look at. Okay. With the continuous fetal monitor under the safety alert, it says the standard fetal heart rate monitoring is every 30 minutes in the active phase of the first labor and every 15 minutes in the second stage. So if any risk factor is present, fetal heart rate monitoring is every 15 minutes in the active first stage and every 5 minutes during the second stage. Okay. And then skill 6.3, it talks about external electronic fetal monitoring, and it shows you how to actually place everything on. Okay, now let's see here. So fetal heart rate outside normal limits. So if any fetal heart rate is outside of normal limits, and any slowing of the fetal heart rate that persists after the contraction ends, is promptly reported to the healthcare provider or the registered nurse that you're working along with. So again, these are some, evaluating fetal heart rate. When you evaluate fetal heart rate patterns, what you're actually looking for, when it comes to the baseline, or if there's a slower heartbeat or tachycardia. So again, really important. So when you're looking at the baseline and the moderate and the marked variability and any absent variabilities. So in your book on page 140 in your book, when you're evaluating the fetal heart rate patterns, we are looking at any type of periodic changes and so forth. So periodic changes are transient, and brief changes of the fetal heart rate that are associated with uterine contractions, such as accelerations and also decelerations. So accelerations going up, decelerations going down. So when you're looking at the baseline fetal heart rate, that's the average fetal heart rate that occurs for at least 2 minutes during a 10-minute period and is averaged over 30 minutes. It is assessed while there are no uterine contractions. So the baseline fetal heart rate should be between 110 to 160 beats per minute for at least 2-minute period. When you're looking at fetal bradycardia, so in fetal bradycardia, it occurs when the fetal heart rate is less than 110 beats per minute for 10 minutes or longer. Causes of fetal bradycardia can include fetal hypoxia, maternal hypoglycemia, maternal hypotension, or prolonged umbilical cord compression. Okay, remember when we talked about that compression, if the baby is coming out, like when we were talking about placenta previa, when we're talking about that, and it's times when to deliver and not to deliver because, you know, the way the baby is presented. So when bradycardia is accompanied by a loss of baseline variability or by late decelerations going down, immediate intervention is required for a favorable outcome. Fetal tachycardia, rapid heartbeat. So fetal tachycardia is a baseline fetal heart rate that is greater than 160 beats per minute that lasts 2 to 10 minutes or longer. It can be caused by maternal fever or maternal dehydration. So when fetal tachycardia occurs along with loss of baseline variability or late decelerations, immediate intervention is going to be required. And then you have the baseline variability, describes fluctuation or constant changes in the fetal heart rate above and below the baseline in a 10-minute window. Variability causes a recording of the fetal heart rate to have a sore tooth appearance, which we will see here in figure 13, with a larger undulated wave-like movements. So baseline variability is a reflection of an intact central nervous system and cardiac status of the fetus. So your books in figure 613, they show these different variabilities and moderate variabilities. All this stuff I'm not going to go through, but it shows you exactly what it would look like. It's really good for you to look at this because sometimes they can come up on your boards to see if you know the difference between the different the baseline and so forth. So it will show you here, it says the recording of the fetal heart rate in the upper grid and the uterine contraction in the lower grid. So you will have what the uterine contractions will look like on one grid when you're looking at a fetal monitor. Like you will see the peaks and the deceleration, not the peaks and when it peaks and how it goes down and how it decels and so forth. Usually, when we said the longer it stays in the peak, the more complications it can cause the baby because that means the placenta is not getting enough oxygen. So this is what these strips are actually showing here in figure 6.3. It shows the recording of the fetal heart rate in the upper grid and the uterine contractions in the lower grid. So the sore tooth appearance of the fetal heart, tracing is a result of constant changings in the rate variability. So basically it says also note the space between each dark black line on the strips represent 1 minute, and the space between each light black line, represents 10 seconds, okay? So that's kind of how you read it. I think I gave you a little assignment on reading the patterns of the strips, but okay. So classifications of interpretation of fetal heart rate and uterine activity um, patterns. Okay, so and we just kind of went through all of that. And it also goes through the categories of the fetal heart tracings and non-reassuring patterns and so forth. So reassuring and non-reassuring fetal patterns and uterine activity patterns. So with the reassuring patterns, again, you're going to have the stable fetal heart rate, the moderate variability. You're going to have those accelerations, nothing, no decelerations. You're going to have the uterine contraction frequency greater than every 2 minutes and duration less than 90 seconds. You're going to have the relaxations, the intervals of at least 60 seconds. When it's a non-reassuring pattern, again, you're going to see the tachycardia, the bradycardia, the decelerations or decrease or absent variability, little fluctuations, the late decels, the variable deceleration. So those are going to be your non-reassuring patterns. So when we're looking at now amniotic fluids, okay? So inspection of amniotic fluid. So when you're inspecting, this is what you want to see. You're going to look at the color, and you want that color to be clear and no flecks or any of that vernix caseosis or removal of the hair or anything, in there. It's okay to, you'll see that. It's okay to have that in there. So you'll see the vernix caseosis and the lanuga. But it's going to be clear. It's not going to be you know, bad, like a different color. So you want to see that clear. Anything that is green stain or may indicate the fetus past, like the meconium, which is the baby's first stool. And anything if it's that color or different, or if it has odor or anything that indicates an infection, um, you know, and also if it's a large amount, we look at all of that. You want anything that's going to show it can lead to some type of fetal compromise. This is when you want to just basically it's not a good thing. So how do you test for it? There's something called a nitrazine test or a burn test that can be performed if it's unclear whether or not the membrane is actually really ruptured or if it's actually bad. So that's cool. So we keep that in mind. A nitrazine test. It's a test. It's a piece of paper, and you take it and you dip it in the amniotic fluid, and then it's going to show you the results. Right then and there. Your book shows you testing in the presence of amniotic fluid using a nitrazine actually paper test. So now you're going to monitor the mom, okay? Because again, the mother comes in, you're monitoring the vital signs, all the contractions, how the labor is progressing. At a certain point, if they're going to do a C-section, they're not going to have nothing input, not like water or anything, but you're going to look at the intake, you're going to look at the catheter if she does have one. You're going to look at the output and how she's responding to the whole labor and the contractions and so forth. So you're going to be looking at all of that. And you're going to be just also describing any type of uterine activities, and how basically again how the labor, how she's responding to labor. Okay. Now with the intake and output, you know, um, so where was I? So policies about the oral intake vary again amongst different facilities where you're going to be working. Sometimes they may allow ice chips to moisten the lips, but usually if it's going to be a C-section, they don't want any type of fluid or anything at all. Some facilities may allow popsicles or something, but it's going to be depend on the facility. Okay. And what else we have? Okay. 6 Lamaze Institute basic practices for maternity care. I'm just looking for that for you. So when it comes to like labor support and so forth, sometimes they have the Lamaze. So labor should begin on its own. No routine intervention should be performed. And women should have freedom of movement and have the birth support, the doula, and everyone else there. And and it also says here on the PowerPoint about no non-supine positions and not to be separated from the infant. And when you're helping the mother cope with labor, of course, you're going to have the labor support there, the teaching, the providing encouragement and supporting, and also teaching the partner. And about like if she wants an epidural, the effects of the whole epidural and analgesia, and what to expect in his or her own emotional response. Okay, and okay. Now, stages and phases of labor. So you have the first stage, which is dilation. So we're going to be looking at all of that. So the first stage of dilation and effacement can last from 4 to 6 hours. And we already spoke about all of this. I'm not going to go through that. But you have the different stages and exactly, the phases and the seconds and how long they usually will last. Okay. And vaginal birth. After cesarean. So the main concern again would be the scarring. Uterine scar will rupture, can disrupt placental, blood flow, lead to hemorrhage, and women may need more support than other laboring women. So, um, and and nurses provide empathy and also support during that time. In your book, it talks about that more on page. Okay, we have support in the partner, teaching, stages of labor. Okay, so vaginal birth after cesarean. So, under that, it talks about the vaginal birth after cesarean. So the physician, usually carefully selects women who are appropriate candidates to do like a vaginal birth after having a cesarean. Women having a vaginal birth after cesarean, again, they're going to need a lot of support other than other women. And the nursing care is going to be similar. But the main concern, again, is going to be the uterine scar and the scar tissue because it's going to be a little bit more difficult, which can, again, it's going to involve the placenta flow and the cause of some type of more bleeding can actually happen. So when you're observing your patient, you're observing signs of uterine rupture, should be part of the nursing care for all laboring women, but regardless of whether they have had a previous cesarean section or not. So nursing responsibility during birth, again, you're going to prepare all the instruments and, um, you know, um, and excuse me, you're gonna be preparing. So, and getting all the medications and everything else. Again, assessing the APGAR score, which we'll go over later. Assessing infant for obvious abnormalities, examining the placenta, which we'll go over later, and identifying the mother and the infant, and promoting parent and infant boarding. Okay. And so your book goes through a whole process of what you're looking at. So when you're looking at the placenta after the delivery, and it gives a great picture here. Remember we said it was the maternal part and the fetal part. So when you're looking at, so the placenta after delivery, we have the Duncan delivery is the maternal side of the placenta. So Duncan means dull and rough. And that's usually comes out first. And then you have the shiny side, which is the Schultz side of the placenta, which is shiny and smooth. We have that part. Okay, if that's delivered first. So you actually see those are the difference, the Duncan side and the Schultz side. So the fetal side of the placenta, which is shiny and smooth, is, this if that part is delivered first. So for example, the placenta, the baby came out, the fetus came out, and then now you have the placenta that's coming out. So which side, they're going to say which side came out first. You're going to say Duncan, or you're going to say Schultz. Which side did you see first? What was presented first? So that's what that actually means. Okay. Immediate postpartum period, third and fourth. So you have all these other stages. So the third stage of delivery would be the expulsion of the placenta, which is the Schultz or the Duncan side. And you have the fourth stage of labor, which the nurse, so that's going to be looking at any bleeding, evaluating, intervening for pain, observing bladder function and urine output, evaluating recovery from any anesthesia if it's a cesarean section, providing initial care to the newborn infant, and also promoting bonding and also an attachment between the infant and also the family. Okay, and nursing care immediately after birth. Again, you're going to be looking at the mother, observing the vital signs, the skin color, and the logia, which is really important for you to look at the pad, making sure that the logia. So you want to be able to identify and look at the logia, and that's going to be, before I go to your book, actually gives the labor process and also the nursing interventions, what you can do for that. So it's a really great chart for you to look at that. And for the logia, so the logia, so you're looking at the logia. So you want to know the different types of logia, and I am going to tell you what page it's on as soon as I don't see it here. Okay, so you have, so you're gonna look at the different logias. So if I see it on the page, I'll actually tell you and give that to you, but I can't find it here. It's probably in the next chapter, I'm thinking it is. Okay, but the chart actually tells you what to actually look at and go through. Again, nursing care immediately after birth. You take care of the mother. You're looking at the logia, the color, logia rubra, the redness, because it's not going to change to the other colors until down the line. And the logia always decreases, never, it should never increase and go back to red. Again, you want to promote comfort, which can be ice to the perineum area to decrease any type of swelling or any type of bruising. Okay. Now we're going to go into the care of the newborn, the different phases and what we do. From birth to hour, phase 2 and phase 3, and what we do and transitioning the newborn to nursery and also to the postpartum unit to the mom. Okay. Again, okay. And we're going to go over in chapter 9 to look more into the logia and looking at the fundus. It's going to be more in chapter 9. We go a little bit more deeper into all of that. This is why the logia is not in chapter 6. So when you care for the newborn, the different phases, so the main thing we want to do is maintain thermoregulation, maintaining cardiorespiratory function, observing for urination and passage of meconium, identifying the mother and the father and the baby, and performing a brief assessment for major abnormalities, and encouraging bonding and also breastfeeding during that time. Okay. And just keep in mind with cold stress. Cold stress is a hypothermia, which is hypothermia that can cause cold stress, and which the increased metabolic rate required to generate body heat causes increased respiratory rate and oxygen consumption. So if the infant cannot supply the increased demand for oxygen, hypoxia will result and cause further problems. So that's going to fall under cold stress. So you want to make sure that you're drying the infant really well, and that you're going to place the infant in a radiant warmer, and then place a hat on the infant's head, and also wrapping the baby in a warm blanket and so forth to prevent any of this cold stress. We also look into maintaining the cardiorespiratory function. Again, you wiping and cleaning the baby and gently do, the bulb suctioning. So you want to make sure that you're doing that. But I think we're going to go through that in a different chapter. And also you want to just perform the APGAR score. Make sure you review that. in your book, it's the APGAR score. You're looking at the heart rate, the respiratory effort, the muscle tone, um, the reflex response, um, to suction or gentle stimulation on the soles of the feet, and also the skin color. So you make sure you look at the APGAR score, the reading for that. And of course, we're going to identify the infant, administer medications to the newborn, such as the vitamin K, um, and also we're going to do eye care. So, where's that? It's in your book. Eye care. So, with the newborns are given a specific eye care because you want to prevent ophthalmia neotorum, which is caused by Neisseria gonorrhea. The American Academy of Pediatrics also recommends protection against chlamydia, trachomitis. So this is why you want to give the erythromycin, which is an eye ointment. That's going to be administered and placed in each eye. And that's going to be given at least 1 hour after birth. Okay. Um, and then any type of medication, like an intramuscular exam, the vitamin K is one of them. And this is going to assist in the blood clotting. And then you're going to observe for any type of other abnormalities like the head trauma, um, you know, um, symmetry and equality of the extremities, the length of the baby. Do they move? Do they move? You're going to look at how many fingers, the digits, the toes, the fingers. All these questions that the parents will actually be asking you. So you're going to be doing that. Umbilical cord blood banking. This type of blood is capable of regenerating stem cells that are able to replace disease cells. So they're going to need some parents want to do this. So therefore you have to have an informed consent in place, collect blood after cord has been clamped, and blood must be transported within 48 hours of collection to the blood bank facilities. Again, the emergency technologies in practice. You have, it's in your book, you can read more up on it, but it talks about technologies. Okay, where is it? STAN technology is a type of waveform analysis that detects intrapartal changes in fetal ST waveforms indicating of developing fetal metabolic acidosis. And then you have the Pericom EFM, which is a computerized interpretation of real-time FHR fetal heart rate patterns that provides automatic analysis of fetal heart pattern to complement clinical judgment as well as permanent documentation in the EMR system. Okay, so that's it for this slide here. And okay, so now, okay. So now this is chapter 7, which is going to be a little bit brief. Okay. So chapter 7 is nursing management of pain during labor and delivery. Oops. Okay. So you have your basic education. So your basic education for childbearing, ideally, educational preparation for childbirth begins before conception that we learned before. You do have the different types of classes that's going to be available for moms, like for gestational diabetes mellitus, early pregnancy, exercise for pregnant women, infant care, breastfeeding, sibling, grandparents, adolescent birth. So you're going to have those different classes available. Okay. Um, so you're going to have those different classes available. But again, you always want to look at your key terms. So again, so you have the education for childbearing. So variations of basic childbirth preparation class. Some people may need refresher courses, of course. Um, you have to, they have classes for mothers who are going to have a cesarean birth, vaginal birth after cesarean, and also for teenagers or adolescents giving birth for the first time. It shows this in your book under health promotion, the types of prenatal classes that they actually have, for the mom. Um, then you have your basic content of the childbirth preparation classes. So, um, they talk about contents that you're going to see. They talk about the changes of pregnancy, how everything you just learned, the fetal development, prenatal care. They go through all these steps, even hazardous substances to basically avoid, nutrition, even, and that way you can add in if the mother does need some type of resource, to help her in regards to that. Common discomforts that they would have, work and benefits of exercise, and also coping, how to cope with the labor and delivery. So then they're going to really talk about the different pains, childbirth pain, what, things to actually help relieve that pain, how childbirth pain differs from other pain, the part of the normal birth. And the woman have several months to prepare for pain management, and also is limited and is self-limiting and rapidly declines after birth. So they go through all of this. So one of the things in box 7.1, it talks about your different selected non-pharmacological pain relief measures. Um, it shows you how they have the different progressive relaxation, touch relaxation. So they have these different non-pharmacological things that they go through, even when it comes to positioning. So they have that. But when it comes to childbirth and also actual pain, how childbirth pain differs from other pain. So you have several factors distinguish childbirth pain from other types of pain. Okay, so it is, okay, give me 1 second here. Okay, so now let's look at childbirth and pain. So how childbirth pain differs from other pain. So childbirth, you know, you have several factors that actually distinguish this. So childbirth pain, it differs from other pain. Number one, it is part of the normal birth process. Number two, woman has several months to prepare for this. And then number three is a self-limiting and rapid decline. So you have factors that's going to influence this labor pain, what we call the pain threshold and also the pain tolerance. Remember, we talked about the different cultural, so it's really kind of a lot of time it depends on that too. So, your pain threshold, also called the pain perception. Um, your pain threshold, oops, sorry. Okay. So your pain threshold, okay. It's not working for me. Why is it not working? Slide's not going. Slide's not moving. Don't know why. It's like the slide is stuck everywhere. I'm not going to be able to use the slide, so I'm just going to go on. Don't know why the slide's not moving. Undo again. Okay. Okay, don't know why the slide's not moving, so I can't use the slide. So you have the pain threshold and also the pain tolerance. Maybe if I stop share, let me go back, stop share, now share. See what happens. Chapter 7. Share. Probably gonna have to do this. So this is how it's working. Okay. So child, okay. And okay, so factors that influence labor pain. So you have the pain threshold, also called, um, you know, um, pain perception. Is the least amount of sensation that a person perceives as painful. And then you have the pain tolerance, is the amount of pain one is willing to basically tolerate or endure. Um, so so you have the different physical factors that actually do this. So your central nervous system has a lot to do with it. The endorphins, which are basically also a natural body substance similar to morphine, your endorphin levels actually increase during pregnancy, and it also reaches a peak during labor. So the endorphins may explain why women in labor often need a smaller dose of analgesic or anesthetic that might be expected during a similar painful experience. So then you also have the maternal conditions that also, show it, like the cervical readiness, the pelvis, the labor, the intensity, and how exhausted the mom is at that time. Because sometimes we're even fatigued. Fatigue reduces pain tolerance and the woman's ability to use coping skills. So many women are tired when labor actually begins because sleep during late pregnancy is very difficult. So the active fetus, frequent urination, shortness of breath, and lying down also can basically interrupt sleep. And the fetal presentation has a lot to do with it, which we talked about in chapter 6. Okay. So again, we always look at the non-pharmacological. Sorry, we always look at the non-pharmacological. Slides get on my nerve, and don't know why that happened. Okay. Okay. Share screen. Chapter. It's like I lost chapter 7. Okay. Okay. There we go. That's chapter 6. So where is my chapter 7? And this chapter 7. Share screen. And chapter 6. Okay. All right. Here's chapter 7. Okay. So of course you want to use non-pharmacological pain management first, because the advantages of, like, number one, it's not going to harm the mother or the fetus. Number two, they do not slow labor if they provide adequate pain control. And number three, they carry no risk for allergies or any type of adverse effect. Okay, and don't know what it's doing that. Okay, this picture. Don't know what this is acting silly today. Mhm. Okay, okay. Now, how to recognize and correct, hyperventilation. So sometimes when it comes to um, non-pharmacological techniques, sometimes they use that because you want to recognize and correct any type of um, hyperventilation that the mother may have. So this right here, the notes here, is showing you how to recognize and correct hyperventilation. It shows you that in box 7 too, because you want to know the signs and symptoms of it. It's on me on page 170. So the signs and symptoms would be number one, when they're breathing and breathing and breathing, they can make themselves extremely dizzy. They may complain of losing oxygen to their extremities, like the hands and also the feet. So you'll see some tingling of the hands and the feet. And then you're going to have maybe they'll complain of cramps and muscle spasms of the hands, numbness around the nose and the mouth, and also some type of blurring of vision. Corrective measures would be, again, you tell them to breathe slowly, especially um, you know, um, especially when exhaling, like breathe in, breathe out slowly. Sometimes this is when you actually bring in that whole Lamaze, bring that in. You breathe into cup hands because of the carbon dioxide. You know, that's gonna kind of build it up, and you want to get them to really get great oxygen level. So you tell them to breathe into the cup hands and place a moist washcloth over the mouth and the nose while breathing, and also hold breath for a few seconds before exhaling. Okay, so your book tells you that how to recognize it and what to do. Um, and Why does the slide do this? I don't know. Yes, I think it's like this. Okay, and don't need that one. Okay, so your role as a nurse when it comes to non-pharmacological techniques, again, you want to determine if attendant, you determine if attendant childbirth preparations have they ever done that? Because sometimes, when they go to these Lamaze classes, the patient tends to kind of have a more relaxation or learn a more relaxation technique. It's going to kind of aids in developing appropriate nursing care plan when you do that, because you can put all those interventions in place and that the patient has been prepared prior to coming in, prior to coming into the hospital, prior to delivery. They're kind of prepared for labor and delivery. They know what to expect. You're going to identify any type of signs of tension, which can aid in determining the appropriate relaxation technique that your patient may need to have, or more things that you may need to do with them. Minimize environmental irritants, like keeping her clean and dry and relaxed, having some ice chips on the side, making her very relaxed. Anybody or anything that's going to interfere with all of this, and she doesn't want them in the room, ask them to leave, because I encountered that before. So any type of environmental irritants can also mean like irritable family members. So you have pharmacological pain. Now, dealing with the pharmacological pain, um, pharmacological pain management. So in your book, it's going to talk about the different pharmacological pain management. I'm not going to go too much into it, but it's going to show you table 7.1. It goes into the analgesics, which are, that they can take for pain, which is more systemic, a different type of relief, the different drugs and the narcotics that they can use. So you want to really look at this. It talks about the use and the effects of it, when to use it. It also talks about the combination of opioid agonists and antagonists, and like when to use it. So this is a really great table. But then again, table 7.2, it goes into the methods of anesthesia administration for childbirth, the different blocks and the nursing implications of when to use it. So those are mostly of all your pain medications that you would actually be utilizing. The anesthesias, you have the regional, just the regular one area, and then you have the general, which is going to give the loss of consciousness and also the sensations. Okay. Um, okay, I'm gonna have to do like that. Okay. Then you have the physiology of relationship of pregnancy to anesthesia and anesthesia. So pregnant women at risk for hypoxia, especially if the infant is going to be losing a certain amount of oxygen. So you don't want to really kind of put more risk of that. Sluggish GI tract can result in increased risk of vomiting and also aspiration. The aortic caval compression, increased risk of hypotension and shock. And also, again, the effect on the fetus must definitely be considered when you're doing analgesia versus anesthesia, which is, the full sedation and being unconscious. Okay. So, slides are like really not my friends today. Okay. So pharmacological methods, again, the advantage, using medications during labor allows the mother to be more comfortable and also relax. It also increased relaxation will aid in her ability to work through contractions. And then it also lessens stress response, which if not controlled could lead to, fetal acidosis. So you have to remember, like a lot of these issues and problems when it comes to pharmacology, placing more meds into your system, or to the mother placing more meds into her system, how it can actually have an effect, on the fetus. And so also in your book, it shows you the different epidural and also the spinal anesthesia. And you could take just a brief overview of it, not to go too deep into it. And just to kind of know the difference between local, and the pudendal block. So for example, the pudendal block anesthesia. So the two pudendal nerves on each side of the pelvis are injected, because basically what they're doing, they're numbing the vagina, the perineal area. And so it basically kind of shows you where they actually do those type of blocks at. Okay, and what else? Okay, and what is this? Okay, then you have the slides on this not working for me today. And do you have limitations? Important factors to consider. You're looking at the mom, you're looking at the baby. So those are going to be your very important factors, whether or not to medicate, depending on the high risk for the mom and also the baby. So any medication used must be considered for its potential impact on the condition of the fetus, because again, this can slow labor if given too early. And you know, even if it's given too late, it can really, the mother be so sluggish that she can't really push. So you always have to look at the timing of when they're actually giving this. Analgesics and adjunctive drugs like the narcotics and the opioids, again, you have a chart that you can look at in your book. You can review that. So you avoid if birth is anticipated within an hour. Like I said, if it's given too early, you don't want to really give an opioid because it's going to can cause respiratory depression and on the baby, because the mother is so sluggish that she can't really help with the delivery. Do you have the regional anesthesia that we talked about too? So the regional anesthesia usually involves placement of the anesthetic or the epidural in the subarachnoid space. And again, you're looking at where in the meninges around the spinal cord is usually done near the dura mater, the acra mater, and also the pia mater. So it's giving usually in those areas. And again, knowing the difference between analgesics and anesthetics. So we just looked at that just now. That the analgesics, they block pain, and anesthetics, they block both pain and also the motor responses. And the types of anesthesia for childbirth, and we talked about one of them, which is the pudendal block. The most familiar one, a lot of you know, will be the epidural block. Okay. And general anesthesia, again, may be necessary for the following circumstances. Again, if it's an emergency C-section, not enough time to establish a block. And we did look at certain conditions that they would need an emergency C-section. If the patient's bleeding and they can't profusely, if they have like a placentia, previa or rupture or something like that, emergency C-sections. Cesarean birth in woman who refuses or has a contraindication to any type of block. Okay. And what adverse effects it can have on the mother. Again, regurgitation with the aspiration of gastric contents. It also can result in a chemical injury to the lungs and also adverse effects on the neonate, again, respiratory depression. And also aggressive resuscitation may also be necessary. And then you have your pharmacological techniques, what the nurse's role is going to be. Again, it begins at admission. When the patient comes in, you're collecting patient data and women's preference for pain relief. Always keep the side rails up because it can make them very groggy, number one. When they're pregnant, they can try to get up and fall out of bed. Keep the beds low. If you keep the side rails up, you want the bed low. Provide education regarding procedures and also expected effects. And you want to observe for any type of hypotension and also respiratory depression. And also, again, documentation is the key, especially when you're planning and implementing after you do your patient assessment, because later on you have to do an evaluation to see if any of those actually worked. Okay? All right, great. So, I'm going to stop sharing. And I'm going to